So thank you. Thank you, Dr. Ackerman. Now we're going to go to the screens, and we're going to hear from Professor Biggs, who's joining us remotely from the UK, all the way. It's a little later there than it is here. He will be talking about his research on this issue and the recent shifts in clinical protocols in European countries. Professor Biggs, you're recognized.
Thank you. Thank you very much for this invitation. So I'm an associate professor of sociology at the University of Oxford. 5 years ago, a few of my students told me to educate myself on the subject of transgender children, and so I read the literature on gender medicine. I was very surprised by just how poor quality the published research was, and also by suspicious absence of some data. So to take one example, the world's largest pediatric gender clinic in London started research on puberty blockers in 2010. In 2018, I discovered that their results had been suppressed, and I campaigned to force the clinic to publish those results. I've now published original research of my own in journals like Archives of Sexual Behavior, Marital Therapy, and the Journal of Pediatric Endocrinology and Metabolism. Because the time is limited, I'm just going to focus on one intervention for children experiencing gender dysphoria, and that is puberty suppression. So puberty blockers are a class of drugs, gonadotropin-releasing hormone agonists, such as Lupron. Lupron is probably the most common brand name you will know in America. These drugs stop the production of sex hormones. For males, these drugs achieve chemical castration, quite literally. The drugs are licensed for a few medical conditions, such as prostate cancer in men and precocious puberty in children, but they've never been licensed to treat gender dysphoria, not in the UK, not in the USA, nowhere in the world. Puberty suppression is intended for juvenile transsexuals, and I use that phrase because that's the title of the article that was published in 1996 to introduce this particular use. GnRHA can be administered from Tanner stage 2, which is the beginning of puberty. And so that could be a girl, for example, as young as 9 years old. Advocates for puberty blockers claim that this is analogous to treating precocious puberty. And that's precocious puberty is when, for example, a girl maybe age 5 might start developing breasts. But that treatment means delaying a puberty that arrives abnormally early so that the child can undergo puberty at the normal age. By contrast, puberty suppression for gender dysphoria means stopping normal puberty in order to prepare the child to take cross-sex hormones for the rest of their life. 96% to 98% of children who start on puberty blockers continue on to cross-sex hormones, and that continuing to cross-sex hormones typically happens around the age of 15. Now, the only robust scientific evidence favoring this intervention comes from a longitudinal study of 70 Dutch teenagers. De Vries et al. In 2014 published outcomes shortly after surgery, so the patients were around the age of 20. Several psychological measures showed improvement, though these measures were taken for only a subset of patients, sometimes as few as 32 individuals. Gender dysphoria also appeared to decline, but the latter finding was probably an artifact of the fact that they switched the measures of dysphoria halfway through the research, as Dr. Levine has been very clear in pointing out. De Vries et al. Acknowledged that one patient was killed by necrotizing fasciitis during the vaginoplasty. So out of 70 patients, they started with 70 patients, that's a death rate exceeding 1%, which is incredibly high for a group of healthy teenagers. De Vries et al. Didn't mention that the death was actually a consequence of puberty suppression, as I'll explain a bit later. The Dutch researchers have recently followed up this patient cohort, but they've not published the results. Therefore, we lack any knowledge of the outcomes in the longer term. And this is for a treatment that has been going on for more than a quarter of a century. The only attempt to actually replicate the Dutch study came from the Gender and Clinic in London, which you might know as the Tavistock. So they administered GnRHA to 44 teenagers. Because they found the results after 2 years weren't positive, the researchers decided not to publish the results. And as I said, my campaign eventually forced them to publish their research and revealed that puberty suppression didn't improve psychological functioning and didn't reduce gender dysphoria. There are now a handful of American longitudinal studies, but they're much worse in quality. Instead of replicating the measures pioneered by the Dutch and also repeated by the British teams, Each American team of researchers chose a different set of psychological measures, and the studies are also flawed by tiny samples, high rates of attrition, which are unexplained, and dubious statistical methods. So what then do we know about puberty blockers? Well, it's certainly true that early puberty suppression produces a much closer resemblance to the opposite sex. Patients are more likely to pass superficially. However, this advantage must be weighed against several serious costs. First, for males, early puberty suppression makes subsequent genital surgery more risky and less satisfactory. The penis is so undeveloped that a normal vaginoplasty is usually impossible. A normal vaginoplasty means inverting the penis, but instead a portion, in this case, a portion of the intestine has to be used to line this newly created orifice. Leakage from the intestines immediately after surgery is what killed that first Dutch patient, the early Dutch patient, at the age of 18. So that was an indirect consequence of puberty suppression. Second, puberty suppression hinders the normal accumulation of bone mass. Up to 1/3 of teenagers who take GnRHA for 2 years end up with abnormally low bone density, putting them at risk of osteoporosis in later life. Sweden has drastically curtailed the use of puberty suppression because one of the patients developed severe osteoporosis at the age of 15, and several more patients also had significant losses or failures in terms of their bone density. I think even more serious are the unknown costs. All the evidence is that early puberty suppression, followed by cross-sex hormones, prevents the development of sexual functioning. There'll be no libido and no capacity to orgasm, or at least that's very likely outcome. What's really astonishing to me is that clinicians who prescribe puberty blockers haven't bothered to study their effects on sexuality. And in fact, the Dutch team, the lead researcher who I mentioned, De Vries, recently said in an interview that libido orgasm was an interesting question, but one that they hadn't studied yet. Also unknown is the effect on emotional and cognitive development. A recent randomized control trial in mice showed that GnRHA caused mice to manifest high levels of stress and high levels of anxiety. Again, it's remarkable that researchers have never studied the effect of puberty suppression on cognitive measures like IQ. Given the accumulating negative evidence and the continuing failure of clinicians to collect data, the English National Health Service in October 2022 released a draft specification for gender services. In a reversal of existing policy, it, and I quote, will only commission GnRHA in the context of a formal research protocol. And that's what I recommended to the Florida Board of Medicine, that they should adopt the same policy. I would argue that puberty suppression should only be offered in a proper randomized controlled trial. Obviously, it can't be blind, but there can be a treatment and a control group which can be compared. Moreover, any trial must guarantee follow-up to continue into adulthood and must guarantee to publish all the data that is collected. Thank you.
Thank you, Professor Biggs. That was